دكتور محمد أسامة البغال موجود. دكتور سامر غانم. سامر إجا من فلسطين ما وصل. دكتور باسل العلول. دكتور محمد الجعبري. دكتور مروان حباب. غسان. دكتور غسان شوابكي.
بنبلش بالسيشن نمبر 5. الدكتور عماد حداد. He's going to talk to us about Hypertension Revisited 2025 ACC/AHA guidelines. تفضل دكتور حداد.
مساء الخير يعطيكم العافية. Changing gears here, we'll talk about medical issues that is extremely important to address for all cardiologists and physicians in general. And I will summarize my topic into 6 essentials that everyone needs to know about as in addressing hypertension. The first one is high prevalence and increasing burden. And we notice this all over the world in generally. And we'll give you some statistics about the prevalence and the burden of hypertension all over the world. The most prevalent and modifying risk factor for the development of cardiovascular disease, including coronary artery disease, heart failure, atrial fibrillation, stroke, dementia, chronic kidney disease, and all-cause mortality. And these are all data. It constitute about 7.5 million deaths every year. So hypertension is extremely important, is a deadly disease, and it is constitute about 13% of all mortality are related to hypertension. So no physician should be unaware of hypertension as a significant disease that needs to be addressed to prevent mortality and morbidity. If you look at the prevalence across the world, you have noticed that in the United States, probably they have lower prevalence compared to Europe. And that probably because of the presence of multinationality metropolitan mix in the United States. However, in European countries, the prevalence is much higher, aging is more, and it's almost a pure white dominant society, although now we see a lot of immigration into Europe. So if you look also at the prevalence between men and women, earlier on the men are more they're having more hypertension. However, when you cross the age of menopause, you will have almost equal, maybe women, they will become surpassing men in the prevalence of hypertension. And if you live to the age of 80s or 70s, almost all patients or all individuals, they have hypertension. So this is extremely important to recognize. So it's not a normal that to have high blood pressure, it is a hypertension and needs to be addressed and treated. Looking at the geographical distribution, you will notice that I marked the Middle East and our region. It has a somewhat prevalence in the middle range. So, and it is increasing with time. If you look at the year 2000, we have a range about 22% of all patients or individuals in the region have hypertension. However, at current age 2025, that ratio has increased to about 25%. So this is really just to give you an idea about the importance of recognizing hypertension as the most prevalent risk factor. This is emphasizing the importance of our data and our research into contribution, not only just consuming a Western data or outside data. We have to be able to produce our data and to know the specification of our patients in general. And this data came up from a study that we published a few years ago. We called it the Jordan PCI study. Those patients who came to the cath lab for intervention, and they have about 2,400 patients. And if you look at the risk factors, you notice that hypertension is the most common and the most prevalent risk factor in our population. So this is not to underestimate the importance of hypertension. We notice that the other risk factors are very frequent in our region, but hypertension is probably the most common risk factor in our cardiac patients presenting to the cath lab. And this is the WHO data telling us that Jordan in regard to hypertension, it is the world rank number 8. So we are world rank number 8 as contributing to morbidity and mortality in Jordan. And if you look at the contribution of hypertension to mortality, you'll notice that the number 1 is cardiovascular disease in Jordan, number 2 is the stroke, number 3 is hypertension. So it is extremely important to know that hypertension is very common, very prevalent, and very deadly disease in our region. So we have to really address it in all aspects, from recognition, awareness, treatment, and even more as a control. And this is the second essential that we have to remember of our hypertension. Hypertension is not a number. It's not 140, 150, 160. It's a disease. It is a combination of cardiovascular, cerebral, and renal disease. So when you see the patient, and this is my practice in my office, when I see a patient with hypertension, I spend 2 minutes to him. I said, the numbers are important, 130, 150, whatever it is the number, but I'm treating a disease here. And I tell him and explain to him, hypertension can lead to heart attack, can lead to stroke, can lead to renal failure, can lead to heart failure. So if you want a proper treatment, you have to treat hypertension as a cardiovascular, renal, and metabolic disease that leads to serious morbidity and of, unfortunately, mortality. And that is probably the best important message to our patients. When he hears that, his attitude is completely different. He was thinking about how I can manipulate the numbers. Now I have to be careful not to get the diseases. So our approach and initial address of hypertension to our patient is extremely important to get them to understand their disease and to be really focused on how to prevent further more fatal disease. Now this is translated into the presence of hypertension, or every 20 degrees increase of systolic blood pressure or 10 millimeter mercury diastolic blood pressure, you have really doubling of their cardiovascular mortality. This is not new, this is old, but it is very important to explain it to the patient so they become more really focused on their treatment and to become compliant and their treatment. The third important essential that I want to address today is the hypertension categories. Fortunately, that the American College of Cardiology, American Heart Association, they have the categories are the same for the last 2 decades. They did not change that. They are much more aggressive than the European or anywhere else. And I guess that is fair because we treat patients that are at the highest risk as a cardiologist, and that is reflected on our guidelines. So I don't see that this is a simplification. This is a realization of how aggressive you need to treat your patients to prevent cardiovascular disease and other morbidities. And just for the people who are not familiar with those, we consider normal blood pressure if you are a systolic blood pressure less than 120 millimeter of mercury and diastolic blood pressure is less than 80. High or elevated blood pressure 120 to 129 and diastolic is less than 80. However, we have 2 stages of hypertension. It's a very simplified approach, a very simplified categorization. Stage 1, when your systolic blood pressure is 130 to 139, or diastolic blood pressure 80 to 89, or the combination. Stage 2, when your systolic blood pressure is more than 140 or 140 and above, and your diastolic blood pressure is 90 and above. It's very simple, very straightforward, and makes us very easy to approach our patients without confusion. Now, this is maybe very basic, but it is extremely important how to measure the blood pressure. Because once the patient hits into the clinic, the blood pressure is taken. It's not right. You have to get the patient rested, relaxed, totally isolated from his environment. مش حامل تلفونه ولا بيسوي مسجز ولا بيطلع على أنباء الحرب ولا بيطلع على أنباء السلم. You have to be really isolated. And it's very difficult to do that. We know all of us have busy practices and we are very busy to do that, but you have to spend time, particularly when you want to diagnose a patient with hypertension in the first visit. We are lucky as a cardiologist that we send the patient to the office, we get somebody to review him, we get him an ECG, so that you spend 10-15 minutes before you measure his blood pressure. So this is extremely important. لما انك ترجع وتلاقي المريض حامل تلفونه خلاص you know that his blood pressure measurements are not correct. So you have to have the patient is a very relaxed environment, not getting into contact with the outside environment, use the right and left arm, measure at least twice, and we have a rule in our clinic that we have 6 times measurements, 3 times on the right side, 3 times on the left side, and sometimes we repeat the blood pressure measurements after doing the echo and so forth. And this is extremely important because diagnosing a patient with hypertension, you are labeling him with a cardiovascular disease and higher risk of mortality. So you have to be fair to yourself, you have to be fair to your patients about proper diagnosis. Now the fourth essentials that we need to approach is how to deal with the therapeutic approach. Regardless whether you are in the east or the west, the south or the north, you are black or white or anywhere else, we notice that there is less awareness of high blood pressure as a disease. Even if you are aware of it, the treatment is not optimal and the control is extremely suboptimal. And this is extremely important to understand. So we have facing this problem because it is a chronic disease. A lot of people, they don't want to take chronic medications, and that's why you are facing a tremendous burden to control and to convince our patients to have a blood pressure that is controlled. However, if you look at the ACC/AHA guidelines, the risk-based threshold for initiation of hypertension is very simplified also. If you have diagnosed the patient with hypertension stage 2, you are entitled to treat the patient immediately before waiting for the 3 to 6 months of holistic approach of controlling blood pressure. However, if your blood pressure in stage 1 or less, you have to risk stratify those patients. If they have the patients who have coexistent coronary artery disease or cardiovascular disease or stroke, or heart failure, those patients need to be treated immediately. If they don't have, but they have a risk, 10 years risk of more than 7.5%, you are entitled to treat those patients immediately. However, if those patients, they don't have disease, they are stage 1 or below, and they don't have cardiovascular risk that is less or more than 7.5, those patients you can wait by giving them a dietary and exercise protocol before you initiating of hypertension. Now this is the data about what is the risk of 10-year risk. It is very simple. You can download it to your phone and you can approach it and apply it to every patient who had hypertension to see if their 10-year risk is 7.5% or more or less, whether it deserves to be treated or you can wait for them. Now, interventions are extremely important because this is also had been addressed in the American College of Cardiology and AHA guidelines. The first is holistic interventions, which means that lifestyle changing, including weight maintenance, moderate exercise, making dietary modification to prevent and treat elevated high blood pressure and hypertension. The second thing is cutting sodium intake and replacing that by potassium intake. But we have to be very careful on those patients who may become hyperkalemic and that may affect their heart function. And then management of stress and eliminating alcohol. These are extremely important. And we said that all categories of hypertension needs this holistic approach. But to move to medications or no medications, it depends on the stage of hypertension. Now, home blood pressure monitoring is extremely important and can actually replace office blood pressure monitoring as long as you really have a good machine that it is approved, and we have a list of machines that have been approved and devices that can be really of worth relying on. Avoid cuff-left devices. Now we have blood pressure measurements through iPhones, through smartphones and whatever. So far they don't have really clear approval and they are not really considered appropriate at this time of recommendations. Now, recommendation for initial treatment and selection of treatment of primary hypertension. For adults who having high blood pressure, drug therapy, thiazide diuretics, long-acting dihydropyridine calcium channel blockers, ACE inhibitors or ARBs are the first line of treatment. It is the same as before, same line of treatment, diuretics, thiazide or thiazide-like diuretics, calcium channel blockers, ARBs or calcium channel blockers. However, if you have stage 2 hypertension, which means that you have to treat the patient immediately, if their systolic blood pressure more than 140 or diastolic 90 or more, initiation of hypertensive therapy using 2 first-line therapies. Usually we prefer to be a combination of therapy, and usually we prefer to be a single pill combination rather than separate pill combination. Now, if you have stage 1 hypertension, which means that the blood pressure 130 to 139 or diastolic 80 to 89, you can start with a single medication and you can up titrate according to the response. The combination of ACE and ARBs are not considered to be appropriate and they are contraindicated. You just choose one of them, even in patients who have proteinuria, which was a real recommendation in the past, but now we don't use it. Now, recommendation for antihypertension, medication dosing once daily rather than multiple time doses. Adult with hypertension using single pill combination is preferred than to taking separate pills, and those patients, we can use reminders to get them compliance and to be treated on time. Now, this is a slide that I want to share with you about the value of single pill combination. This is a combination of valsartan and calcium channel blockers, and you will notice that the single pill combination gives you a very effective lowering of blood pressure. However, you have to remember that the baseline blood pressure dictates the response, which means that if the patient having mild hypertension, his response to single pill combination is less. For example, 20 millimeter mercury reduction systolic blood pressure. However, if the patient having baseline hypertension of 180 or more, he can have a 55 to 60 millimeter mercury reduction with a combination therapy. So your baseline blood pressure dictates your response, and this gives you an idea how to initiate the medication and which medications and combination you can use. Now, this is the adding hydrochlorothiazide to combination of valsartan calcium channel blockers. Similarly, you can have a much higher response when you have baseline blood pressure is elevated, and you can have up to 56 millimeter mercury reduction with a triple combination of therapy. Now, the value of the valsartan is beyond just controlling the blood pressure. It is translated actually in heart and life protection, as demonstrated in patients with VALHAFT trials and the VALUE trials, reduction of the development of diabetes mellitus. What are the targets and the goals for follow-up? We noticed that the American College of Cardiology dictated that the guidelines should be achieving a systolic blood pressure of 130 or less, and diastolic blood pressure of 80 millimeter of mercury or less. And this has to be confirmed by long-term follow-up with the blood pressure. Now, the patients with heart failure, you can prevent development of heart failure if you pre-treat hypertension and controlling their value to systolic of 130 or less and diastolic of 80 or less. You can actually prevent congestive heart failure. This is a summary what I mentioned, that the stage 2 diabetes, stage 2 hypertension, you need immediate treatment. Stage 1 and less, you look at the combination of therapy in addition to risk factors to initiate therapy. But all of them, as you mentioned here, they need a lifestyle modification. So lifestyle modification for all, but initiating of hypertension depends on the stage and the associated risk factors and the 10 years risk of cardiovascular disease in the future. Now, this slide is a very important one, which was just published 2 weeks ago, looking at personalization of blood pressure control. Now, we noticed that there are certain patients, they don't tolerate the guidelines directed numbers, which means if you give them control of systolic blood pressure 130, they become druggy, fatigue, malaise, and so forth. And this study looked at the two large pooled trials of 19,000 patients, the SPRINT and the ACCORD. And they looked at the control of the blood pressure and the associated cardiovascular mortality over time in relation to frailty and age. And what they noticed that if you have a frail patients, it deserves to keep their blood pressure 10 millimeter mercury higher than if they are not frail, because their long-term morbidity and mortality is much less if you have higher blood pressure and frail patients. This
one minute, Dr.
differentiation did not really work with age. So age is the differentiating factor for keeping a personalized different blood pressure control. Frailty is. So frail patients, they deserve to have a slightly higher blood pressure to avoid morbidity and mortality. And this gives us an idea about special personalization of blood pressure control and development. Thank you for listening, and this is the end of my presentation.
Amazing. Amazing, Dr. Imad. Actually, right on time. Thank you for a great presentation as always. And I agree with you. This is a very important topic we have to take care of. I'm going to introduce our next speaker, Dr. Zaher Kassih, a very well-known cardiologist, an amazing speaker also, optimizing the management of patients affected by cardiorenal metabolic conditions, role of empagliflozin.
Assalamu alaikum. It's my pleasure that you are attending this meeting. I would like to thank Boehringer Ingelheim for inviting me to give this lecture. So I'll be talking about the management of patients with cardiorenal and metabolic conditions, the benefits of the SGLT2 inhibitor empagliflozin. Cardiorenal and metabolic conditions pose a high disease burden globally. Approximately 50% of people diagnosed with heart failure will die within 5 years of diagnosis. And the estimated global prevalence of chronic kidney disease is more than 11%. Chronic kidney disease is asymptomatic in its early stages, which contributes to low awareness of the disease in people with chronic kidney disease. The prevention of type 2 diabetes is high and rising. The prevalence of type 2 diabetes is high and rising across all regions. And there is a large unmet need in heart failure with a scarcity of approved therapies in patients with heart failure with preserved ejection fraction. Now, cardiorenal and metabolic conditions, they frequently coexist because they are interconnected. Up to 60% of people with chronic kidney disease have cardiovascular disease. And 30 to 40% of people with heart failure have chronic kidney disease. Up to 40% of people with type 2 diabetes have chronic kidney disease, and 16% of people with heart failure have both comorbid type 2 diabetes and chronic kidney disease. 20 to 40% of people with heart failure have type 2 diabetes, and approximately 1 in 3 people with type 2 diabetes have cardiovascular disease. So these three conditions are interconnected: chronic kidney disease, type 2 diabetes, heart failure, arteriosclerotic cardiovascular disease. Early intervention is the best way to help protect patients by reducing the risks associated with these interconnected conditions. Any one of these conditions, the cardio, renal, and metabolic conditions, can amplify and accelerate progression across other cardiorenal and metabolic conditions. Now, this is to show the early and multifactorial intervention being the best way to help protect patients by reducing the amplifying risks associated with interconnected cardiorenal and metabolic conditions. Now, this is a continuum over time, showing that the patient in the left panel would be diagnosed with a cardiorenal metabolic condition, let's say could be a chronic kidney disease, heart failure, or type 2 diabetes. He would have one of these issues initially, then the patient may develop additional cardiorenal metabolic risk factors. He would add another condition, and then after that, the patient can progress to 2 or more cardiorenal metabolic conditions. Finally, there would be a coexistence of 2 or all 3 cardiorenal metabolic conditions together, associated, of course, with increased mortality. This is to show that empagliflozin has demonstrated improved glucose control in people with type 2 diabetes, as well as cardio and kidney benefits in people with CKD and or heart failure independent of type 2 diabetes, starting at phase 3 trials showing metabolic benefits in people with type 2 diabetes, going into the EMPA-REG outcome trials showing cardio and kidney benefits in people with type 2 diabetes and cardiovascular disease, then going into the Emperor trials, and then finally EMPA-Kidney. EMPA-Kidney showed cardio and kidney benefits in people with CKD independent of type 2 diabetes at baseline. Cardiac benefits in people with heart failure are usually independent of type 2 diabetes at baseline. Whether the patient is diabetic or not diabetic at baseline, he would still obtain significant benefit of using an SGLT2 inhibitor, namely empagliflozin. Empagliflozin provides triple protection by reducing risk for a broad range of your patients. Let's say the patient has a combination of type 2 diabetes and cardiovascular disease. There would be a 38% relative risk reduction in cardiovascular deaths and 32% reduction in all-cause mortality. Now, looking at patients with heart failure, those with HFrEF, they have a 25% relative risk reduction in cardiovascular death or hospitalization for heart failure. In HFrEF, defined as an EF more than 40%, these patients, they have a 21% relative risk reduction in cardiovascular death or hospitalization for heart failure. In those with chronic kidney disease, there was a 28% relative risk reduction in kidney disease progression or cardiovascular death. In addition, empagliflozin provides metabolic benefits in patients with type 2 diabetes, including reductions in HbA1c, reduction in systolic blood pressure, and some reduction in body weight. In the EMPA-REG outcome, empagliflozin demonstrated cardiovascular and renal benefits in people with type 2 diabetes and cardiovascular disease. Again, there was a 14% relative risk reduction in the 3-point MACE. This was the primary outcome. There was a 38% relative risk reduction in cardiovascular death, 35% relative risk reduction in hospitalization for heart failure, and 39% relative risk reduction in incident or worsening nephropathy. So whether you are looking at heart failure, cardiovascular death, nephropathy, or the 3-point MACE, empagliflozin provided significant benefit. Now, looking at kidney function, empagliflozin was found to reduce the decline in kidney function in people with type 2 diabetes and cardiovascular disease. The reduction in estimated GFR decline started from week 4 and was sustained through 3.5 years as compared to placebo. You could see it crossing the line going to the significant difference as compared to placebo, with saving the decline in kidney function or reducing the decline in kidney function. Now, looking here at the guidelines, diabetes guidelines recommend early use of SGLT2 inhibitors in patients with type 2 diabetes regardless of metabolic parameters. Now, so here in patients with type 2 diabetes, if they have an additional ASCVD or indicators of high risk, the recommendations are to use either an SGLT2 inhibitor with proven cardiovascular benefit like empagliflozin, or to use a GLP-1 receptor agonist with proven cardiovascular disease benefit. If the HbA1c remains above the target, then you could combine both, and then you could consider after that a TZD. For patients with type 2 diabetes and heart failure, the recommendation is to start an SGLT2 inhibitor with proven heart failure benefit like empagliflozin in this population. And in patients with type 2 diabetes plus chronic kidney disease, preferably you should start with an SGLT2 inhibitor with primary evidence of reducing chronic kidney disease progression, or you could use a GLP-1 receptor agonist with, again, proven CKD benefit. And finally, you could combine both in any one of these conditions. Now, to look here at the 2023 guidelines for the management of cardiovascular disease in patients with diabetes, it says here that it is of utmost importance to screen all patients with diabetes for heart failure to allow early implementation of life-saving therapies. And the screening is a class 1 level of evidence B to order BMP or NT-proBNP for these patients in order to diagnose if these patients have heart failure. Now, this is to show the 2022 ADA consensus, showing the stepwise approach to evaluate and diagnose heart failure. Of course, the stages are stage A, which means at risk for heart failure. Stage B, those with structural disorder like systolic or diastolic dysfunction or left ventricular hypertrophy or chamber enlargement or valvular disease. And stage C or D, those patients who are symptomatic and they have signs of heart failure. The recommendation, again, as you see in the left panel, is to go and obtain the biomarkers, NT-proBNP, BNP, or the high sensitivity cardiac troponin. If it is elevated, then you obtain echo, and then, of course, thus you would diagnose heart failure with preserved or reduced ejection fraction. So the measurement of a natriuretic peptide or a high sensitivity troponin is recommended, and this recommendation is every 6 to 12 months. Heart failure has a huge burden. 1 in 5 people would develop heart failure. It is the #1 cause of hospitalization in people more than 65 years. Around 30% of those admitted to hospital are readmitted within 90 days, and around 30% of these patients would die within 1 year of hospitalization for heart failure, and around 50% would die within 5 years. Now, the proportion of hospitalized patients with heart failure with preserved ejection fraction has increased over time. In the middle panel, you could see that it has increased from around 32% in 2005 to more than 50%. Currently, more than 50% of the patients have HFpEF. And less than 40% of the patients have HFrEF, with a decline from 2005 numbers, and around 15% they have heart failure with mildly reduced ejection fraction, defined as an EF between 40 to 50%. So there is still there's still high unmet need in heart failure, because 50% of these patients with heart failure die within 5 years, and there remains an urgency to improve outcomes for patients with heart failure. Now, looking at empagliflozin, setting new standards in heart failure management. Now, this is to show 2 phase 3 trials investigating the efficacy and safety of empagliflozin as compared to placebo on top of standard of care in heart failure across the LVEF spectrum. And the left panel are those patients with a reduced ejection fraction below 40%, HFrEF. The trial was the Emperor reduced, over 3,700 patients with heart failure with an EF less than or equal to 40%, with an estimated GFR of more than or equal to 20 milliliter per minute. And in the right panel, you have patients with mildly reduced EF with an EF between 40 to 50%, and those with an EF more than 50%, HFpEF patients, and those were true HFpEF patients, not improved ejection fraction. And those patients were over 5,900 patients with an EF with a GFR more than 20 milliliter per minute or equal to 20. These patients, they were aged more than or equal to 18 years with a chronic heart failure NYHA class between 2 to 4. They were randomized to an MPAM 10 milligram plus standard of care or placebo plus standard of care, looking at the composite primary endpoint, the time to first event of cardiovascular death or hospitalization for heart failure, the secondary endpoint of first and recurrent hospitalization for heart failure, and the slope of change in estimated GFR from baseline. And these are the results in Emperor reduced and Emperor preserved. In the left panel, the Emperor reduced, showing an early and sustained risk reduction in cardiovascular death or hospitalization for heart failure, starting as early as 12 days. with 25% relative risk reduction in cardiovascular death or hospitalization for heart failure. In the right panel, you have patients with the preserved ejection fraction. Again, there was an early and sustained risk reduction in cardiovascular death or hospitalization for heart failure, with a 21% relative risk reduction in cardiovascular death or hospitalization for heart failure. Now, in heart failure patients across the ejection fraction range, empagliflozin is the only treatment that protected the kidney by slowing the decline in renal function in patients with heart failure. Whether we look at patients with reduced or preserved ejection fraction, there was a 2 to 4 times slower decline in kidney function with empagliflozin as compared to placebo. Now, this is to show now here the recommended drugs in patients with heart failure with reduced ejection fraction. Those are the 4 pillars of managing patients with HFrEF. As you see here, it's a class 1 level of evidence A, which is the highest level of evidence and recommendation for empagliflozin and dapagliflozin being recommended for patients with HFrEF in order to reduce the risk of heart failure, hospitalization, and cardiovascular death, just like the ACE inhibitors, beta blockers, and MRA, and better than the recommendation of ARNI, which has a class 1 level of evidence B. Now, these are the ESC 2023 guidelines for patients with heart failure with mildly reduced ejection fraction. It is a class 1 level of evidence A to use an SGLT2 inhibitor, whether EMPA or DAPA, in patients with mid-range or mildly reduced ejection fraction to reduce hospitalization for heart failure and cardiovascular death. In the right panel, those are patients with preserved ejection fraction, again, class 1A, class 1A level A evidence for cardiovascular death and heart failure hospitalization. Now, looking at the kidney now. Now, looking at the kidney, it is that early diagnosis and intervention in chronic kidney disease is crucial for patients with known risk factors. Early screening and diagnosis of chronic kidney disease is indicated. You have to determine known risk factors, including high blood pressure, type 2 diabetes, cardiovascular disease, obesity, and or signs and symptoms of chronic kidney disease. You should screen regularly using urine albumin creatinine ratio and estimated GFR. And these tests would provide the evidence needed for an early diagnosis. Now, chronic kidney disease is a progressive disease and acts as a cardiovascular risk amplifier. By the time the hypertension or type 2 diabetes are diagnosed, structural kidney damage may already be underway. And patients with chronic kidney disease are 3 times more likely to have a cardiovascular event. By the time estimated GFR falls below 60 milliliter per minute, significant kidney damage may be present. So early screening and intervention can slow the progression of CKD and reduce cardiovascular risk and related outcomes. You have to monitor urine albumin creatinine ratio, and you have to monitor estimated GFR. Now, looking here at EMPA-KIDNEY. EMPA-KIDNEY was the broadest SGLT2 inhibitor kidney trial to date, as defined by estimated GFR and urine albumin creatinine ratio. Now, this is unlike other SGLT2 inhibitor kidney trials. EMPA-KIDNEY enrolled patients with estimated GFR as low as 20 milliliter per minute up to 90 milliliter per minute. So there were patients with 20 to 45, with 45 to 90, and urine albumin creatinine ratio more than or equal to 200 milligram per gram. And they were looking at A1, A2, A3 levels of albuminuria less than 30 to 299, and over 300, and looking at the stage of kidney dysfunction from G1 to G5. And they compared it with other trials like the Cardence trial and DAPA-CKD trial. In EMPA-KIDNEY, empagliflozin reduced kidney disease progression or the risk of cardiovascular disease, death, and reduced all-cause hospitalization. And there was a 28% relative risk reduction in kidney disease progression or cardiovascular death, and 14% relative risk reduction in first and recurrent all-cause hospitalization. And the benefit was consistent and consistently proven across the patients you see with and without type 2 diabetes, and those with less than with more than 20 milliliter per minute up to 90 milliliter per minute GFR, those with and without prior cardiovascular disease, and whether they were on or not on a RASI prior to that. Empagliflozin helped protect people with CKD by slowing the decline of renal function over time. There was a 2 times slower decline of renal function over time as compared to placebo. So you could see here that you could delay the onset of dialysis by 27 years if you start empagliflozin at a stage of GFR of 85 milliliter per minute. You could delay dialysis by 16 years if you start at 55 milliliter per minute, and only 2 years if you start at 20 milliliter per minute. And the usual dose is 10
1
milligram
minute.
for patients with heart failure, CKD, or type 2 diabetes, and GFR at least 20 milliliter per minute. For those patients with an
1
estimated
minute.
GFR more than 60, you could go up to a dose of 25 milligram if you need better glycemic control. Now, this was recommended by the guidelines of multiple organizations, as you can see here. And finally, you obtain improved kidney function outcomes. You prevent the decline of kidney function, improvement in uric acid, and also reduction concerning the heart, reduction in hospitalization for heart failure, improving heart failure symptoms, reducing the risk of cardiovascular death, reducing blood pressure, and for the metabolic conditions, you obtain HbA1c significant reduction in addition to weight loss. Finally, my final slide, it is that early intervention with empagliflozin can help protect your patients at risk. Early screening, diagnosis, and intervention with SGLT2 inhibitors can protect people with CKD by reducing risk of cardiovascular death or kidney disease progression. In heart failure patients, whether they are HFpEF or HFrEF, you could reduce the risk of cardiovascular death or hospitalization for heart failure. For those patients with type 2 diabetes and cardiovascular disease, you could reduce the risk of cardiovascular death. Now, a holistic management is required. You have to take the patient in total. A holistic management for patients with people with CKD, heart failure, or type 2 diabetes due to the interrelated cardiovascular, renal, and metabolic systems, and established safety profile and a convenient once daily oral dosing. And in the international guidelines, they recommend using empagliflozin as an early foundational therapy. Thank you very much.
Thank you. Thank you, Dr. Kassih. We have a question for you. I was going to ask you the empagliflozin 25 milligrams higher dose. Any benefit from a higher dose from a cardiovascular benefit?
Actually, the trials were done on a 10 milligram. There were no data on the 25 milligram. And you have to have a good kidney function to put the patient on a 25 milligram. We have no data. The data is for the 10 milligram. 10 milligram is the standard dose of empagliflozin.
Okay. Thank you.
Thank you very much.
It's our pleasure to invite Dr. Raed Awaisheh to present his lecture about LDL cholesterol under control, the new era of treatment with LEQVIO. Also, it's my advice for you, Dr. Raed, to try to change your initials in the hospital. Don't sign with RA. Really? Because already your salary is going to Dr. Raed Aql, and he mentioned that in the previous lecture.
والله I told him, قلت له دكتور رائد يعني I have some patients who have, فقال لي بدل ما يقول لي okay I will return them back to you, أو قال لي work more, do more cases. شكرا. I'm not good actually in presenting for medical. I know I like intervention and to present for intervention, but my mission actually is to talk about the importance of the dyslipidemia and how we treat it these days. So my mission actually is to show how much it is important, and this is well-known slide for everyone, even for the medical students. The importance of the atherosclerosis actually starts from the deposition of the lipids in the subendothelial, and it's progressing there, and then it will cause the myocardial infarction and the ischemic stroke. So the important thing about it, that any risk factor that the patient have, either diabetes or hypertension, smoking, obesity, or whatever, by the end of the day, you need the LDL to have the deposition to have atherosclerosis. My hypothetical question, if we don't have LDL and we have all the risk factors, what will happen? This is really a question we need to everybody to think about, not as medical student, but also as a senior researchers. If we don't have LDL, I think if we take the examples from the mammalians, the big mammalians like the whale and the lion, who eats or which eats meats, what's their LDL level? Their LDL level is very low, and the atherosclerosis risk and to have myocardial infarction or strokes in them is very, 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 very low, or maybe it is not there. Also for the infant LDL level is almost zero, isn't it? And in spite of that, the hormonal function and the brain function and the development of the brain is continuing in the embryo and in the fetus without LDL level in the blood. So the two important points from the first slide, that the gun in the hand of all the risk factors ends with the deposition of the LDL in the endothelium. That's why it is very important actually to disarm all the risk factors from the very important gun, which is the LDL. So this is the importance of taking the LDL down. When we come to the disease burden, either for mortality or for morbidity, we know that the cardiovascular death and the cardiovascular morbidity and the cardiovascular death is more than even any cancer in men and women, as you know. And in Jordan, the most important cause of death of non-communicable disease is also the cardiovascular mortality. And when we come to the different ways actually of atherosclerotic disease, either for myocardial infarction or stroke or peripheral vascular disease, you have the death due to them. And in every 60 seconds, all over the world, you have 34 people, they die because of that. Now, the patient who had a stroke or had MI definitely had recurrence, and the recurrence is very, 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 very frequent and very fast. And the MACE is double times for patients who have atherosclerotic disease. So it is very important actually to prevent or to have not only primary prevention and also for secondary prevention. So we need to achieve the target. And the problem that we are not achieving the target. We have unmet needs actually to decrease the LDL. The modifiable risk factors, almost 90% of the risk factors for atherosclerosis, they are modifiable. So only maybe age and the race are the one that you cannot change, but the other risk factors, they are all modifiable. And the best thing actually to modify it is to modify the LDL. Why? Because the LDL is very clear actually that they have linear relationship with the atherosclerotic disease. And it is not only the lower is better as per the studies, either for decreasing the LDL, decreasing the atherosclerosis burden, and improving the morbidity and mortality. And the lower is better, and the earlier is better, and the continuity, the longer is better, as much as you have really a good control in the LDL level all the time, you achieve a better outcome. And because it is linear relationship, it is very easy actually to calculate it and to know the risk according to how much you decrease the LDL. It reflects in how much you will decrease the MACE or you decrease the atherosclerosis disease, either for myocardial infarction or either for all-cause mortality or for the stroke and for every one of them. Nowadays, we are assessing the patient not according to the LDL level. We assess the patient according to the risk. How much risk does the patient have, isn't it? We look at the patient, we try to find out how much risk he has. Either he has low risk, moderate risk, high risk, or very high risk, or even extreme risk. So when I start the medication or treat the LDL, I don't treat it according to the LDL level. These days, we are not initiating the treatment according to the level. We initiate the treatment according to the risk that the patient carries. And after that, why do we do LDL? Just to see, is the patient achieving the target or not achieving the target? It is for follow-up. We do the LDL for follow-up. So we start or we initiate the treatment for the risk. And when we start it early, that will be better. The lower is better. And sustained controlling the LDL is better. So we have 3 betters, not only 1 better. And when we come to the studies, how many patients achieving the target by the usual medication or standards of care, we find that 80% of the patients, either for primary prevention or secondary prevention, they are not achieving the target. So we need medication to be given, and these medications, when we give it, we need something to have a patient with good adherence so we will be able to achieve the target. In our region, for example, in this dialysis study, we have in Jordan and Lebanon and in the Gulf countries, 60% of the patients, they are not achieving their target. In spite of the need of achieving the target, 60 to 70%, they are not achieving the target. So what is the solution? The solution is to really to think about something other than just statin. And this is the second point, the second concept or the second message I would like to deliver is to talk these days about the lipid lowering therapy. We are not talking anymore about just single therapy for treating the dyslipidemia. And when we come to the adverse any side effects for very low level of the LDL, we don't see significant side or adverse events. And as I told you, when we have the LDL lower, that doesn't mean that you will have side effects, either on the brain, endocrine function, whatever you name it. So reducing the LDL actually is not a problem. Maybe the problem with giving the medication, for example, the statin and how it causes the problems in the liver, in the muscles. But actually, by reducing the LDL itself, we don't have side effects as human beings. So the clinical value actually of having another medication for lipid-lowering therapy other than statin, we have the statin, we have the ezetimibe, the well-known combination, and also we have the siRNA medications like inclisiran. And this medication, the importance of it, that once it goes to the cytoplasm, the mechanism of action, once it goes to the cytoplasm, it increases the receptors for the LDL, so it can uptake the LDL from the bloodstream and decreasing the LDL level significantly. So the studies which were done on these medications, the published ones are Orion 8, 9, 10, and 11. In some group of patients like the familial hypercholesterolemia, patients who have atherosclerotic cardiovascular disease or risk of atherosclerotic cardiovascular disease, and Orion 8 for patients for long-term and sustainability. And what it showed that the LDL level was reduced by 50% by initiating this inclisiran immediately for patients on standard medications. And the early reduction, even in the first 2 weeks, you almost achieve the 50% reduction of the LDL level. This is constant for all Orions, 9, 10, and 11, hypercholesterolemia, familial, atherosclerosis-like. For all of them, almost with the same percent of 50% reduction. And this is only not only reflect on the LDL, but also reflect on the MACE, which is very important for a patient who will have atherosclerotic cardiovascular disease. And the reduction in MACE is 26%. And another important point is the sustainability of having the reduction. So some medications, you have reduction at the beginning and then it goes up. In these medications, no, you don't go up, and you have the significant reduction, and it is maintained. That's why Orion 8 showed the sustainability and the long-term effect on the LDL level. So by having this, you increase the patients that they achieve the target. So 80% of the patients already achieve the target, decreasing the LDL level by 50%, and almost there is no adverse side effects. So this will reflect definitely in the algorithms and in the guidelines. And lipid-lowering therapy now is the term. It is not just statin, ezetimibe, and PCSK9. And the other important point is to start it now as per the guidelines in 2025, to start it once you are not achieving the target, and also in another group of patients who are not tolerant to statin. So these are the two indications to start the medication. Now for Victorian inception, this is for the group of patients where you need to start it, it showed the importance of starting the patient on inclisiran very early. So not to wait and to put the patient on the standard medication and wait for a while of time, and then this one, once you don't achieve the target for a patient with high-risk patients below 70 and extreme or very high-risk patients below 55, you start the medications from the beginning. Would this reflect on a good result? Is again, here, if from the third month, it showed that there is almost sustained 50% reduction than in the usual care. And by doing this, the percent of patients, they achieve the target more than 70% for patients that you need to get them below 70 milligram per deciliter, and almost 60% for patients you want to get them down below 55%. So this is also reflect on what? Reflect on MACE. 50% reduction of MACE from 7.5 to 3.5 reduction. So this is 50% reduction also in MACE. And when we come to the adverse outcome, there is no difference. So the conclusion, to start it, the lower is better, and this is established the idea of the lower is better, and also the earlier is better. Now, that's why it's reflected in the guidelines now, and to go, once you don't achieve the target, you go with the triple therapy, or even to start the inclisiran immediately with the statin. I will go to the I will go to the initiate. Sorry, I will go to inception. No, I will go to this one.
Raed.
Yeah.
Raed. أعطينا 2 minutes شوية discussion. شو رأيك؟
Yeah. Actually, I'm finishing. I'm finishing actually. For a patient with acute coronary syndrome, just to mention that for Victorian inception, yes, for the patients who not only for initiate, for patients who after acute coronary syndrome. This is very important as cardiologists. Post-acute coronary syndrome, to go with with inclisiran from the beginning, and we achieve 50% reduction, and we achieve the target and decreasing the MACE. This is the message I want to deliver. I have some cases. We did these are two cases of mine, and one of them very important. Actually, we started him on inclisiran 2 years ago, and he was having diffuse disease in the LED, CIRC, and RCA. You know, the distality, you cannot do any intervention for them, and it showed marked improvement even in regression of the plaque. And this is very important point actually. Now, not just doing intervention to reduce the lesion or decrease the size of the lesion or improve the flow. You have also doing it by giving the lipid-lowering therapy, including inclisiran. Thank you.
شكرا يا راد، شكرا، يعطيك العافيه. طيب اول شيء يعطيك العافيه. طبعا المحاضره في كثير اسئله، يعني انت عارف الليكفيو الان جديد في السوق وبدا ينزل وي نيد ات، يعني اتس يعني. طب بس لانه احنا في عندنا 3 minutes وي ويل يوز ات، عشان انت شايف المحاضرين عم بيطلعوا وبرجعوش. ف في عندنا some questions about that. احنا we know now الكونسبت in general lower is better, early is better, sustainability is better. Would you want to replace اللي هو الستاتين with the PCSK9 inhibitors even في primary prevention?
Yes.
What do you think about this one? The second one, in the pregnancy, is there is any data about the PCSK inhibitors in general, or LEQVIO especially, يعني? What do you think?
Great. First of all, for primary prevention, to go with the lipid lower therapy, we go with the risk. We assess the patient risk.
Yes.
If the patient is high risk or very high risk or extreme risk, yes, we start first with the statin. This is for primary prevention. We start with the statin. If the patient is not tolerant to the statin, not achieving the target, definitely we go immediately to upgrade. We go for lipid-lowering therapy, and including inclisiran as triple therapy in the guidelines 2025, to go with the triple therapy to achieve the target.
Okay.
For pregnancy, as inclisiran till now, it is very difficult actually to build a study in a pregnant lady, not only for inclisiran, for any medication. All what we know about pregnancy from the medications, as you know, by the self-experience or for long-term experience. And this medication till now is not for a long term to tell yes for pregnant ladies it is safe or not.
يعني احنا الان طب okay, I agree with you about the pregnancy, but about the I'm saying about the patient whose LDL is for example 150 or 160, and you want to start with him, he just have only hypertension, and by his شيء preference he want بحكي لك انا ما بدي اخذ حبه كل يوم، انا just بدي اخذ الابره هاي كل شهر وانهي الموضوع. Would you want to do that? Will you not to give the patient benefit of a statin and هاي الفكره الموضوع other than lowering the LDL only, which is anti-inflammatory, and others all the studies before which is improve the outcome?
Orions actually is going to answer, the coming Orions are going to answer this question by the study, but for my own, if you will ask my own experience or what I do exactly, I want to achieve the target. If the patient will not take the tablet daily and he's happy to take it every 6 months as per injection, it is better than doing nothing or to give him the medication and will not take it. Yes, I will go with inclisiran alone.
Thank you.
Any more questions?
Any questions from the
I still have 1 minute if you want to challenge me.
بدنا الدكتور محمد جعبري، تفضل. لنا الآن محاضرة عن anti-platelet therapy and how to deal with the escalation and de-escalation of the anti-platelet therapy.
سلام الله عليكم. شكرا يا دكتور غسان.
السلام ورحمة الله.
بدنا البوينتر. سؤال: are antiplatelets clopidogrel, prasugrel, ticagrelol are the same in acute coronary syndrome? خلينا نشوف.
شو السؤال؟
Are the antiplatelet in acute coronary syndrome the same, clopidogrel, ticagrelol, prasugrel, or there are differences, and what are the differences between the three groups? First of all, post-myocardial infarction patients are at high risk to develop ischemic event and require appropriate cardiovascular protection. We have 1 in 5 من المرضى اللي عندهم acute coronary syndrome patient will suffer another myocardial infarction or cardiovascular death or stroke within the first year. That's why we need a potent antiplatelet. Also, patients with a history of ischemic events such as MI, stroke, had a continuous and linear risk for the MACE in the coming 3 years. And still, there is a risk to develop another myocardial infarction or another ischemic event all over his body. Also, this is very important that the risk of recurrent myocardial infarction was twice as high in non-culprit vessel versus the culprit lesion. This is very important. And also the non-culprit lesion, recurrent myocardial infarction are more likely to develop non-ST elevation myocardial infarction than the ST. And that's why we need, again, potent antiplatelet for these patients to avoid the risk of developing another attack in the non-culprit lesion. Here is the antiplatelet therapy and the evolutions of the antiplatelet, starting from aspirin in 1980s, then Teclo, كنا بنعرفه, then clopidogrel, then dual antiplatelet, then prasugrel in 2009, and then ticagrelol in 2011. And this is all in the studies such as Capri, such as Awaisheh, such as Comet, all the studies regarding the antiplatelet. سؤالي لكم اللي سألته في بداية المحاضرة. Number one, this is clopidogrel. All of us know that sometimes we load him with 300 and sometimes 600. You must pay attention that among the patient with high post-platelet aggregation, after 300 milligram clopidogrel, we have 62 to 65% non-responsive. And the non-responsive was lower with the loading 600 milligram compared to 300. This is very important. Okay? طيب, what about these antiplatelet? Let's start with ticagrelol. Ticagrelol is the only B2Y12 inhibition platelet with direct acting. They does not need the liver to metabolite. Once you take the tablet, it's immediate action. Okay? And also, not only that, we have a dual inhibition, dual mechanism for the ticagrelol. Number one, inhibition of B2Y12, and number two, inhibition of the ENT1 receptor transporter. And in inhibition of the ENT transporter, it will enhance the adenosine. And every cardiologist in this room, once we said ticagrelol, the first word come to his mind is dyspnea. Yes? Why? Because of the accumulation of adenosine. Look in the coming slides. There is a benefit of the adenosine accumulation in these patients. What is the benefit? First of all, you see here on the lung, all of us know that accumulation of adenosine will increase the incidence of dyspnea. What about the blood vessels? What will happen of the adenosine? You know that ticagrelol increased the adenosine induced increasing in the coronary blood flow. Also, the adenosine itself, it will increase the vasodilatation effect of the blood vessels and also increase the endothelial cell migration. This is a benefit for the accumulation of adenosine. Number two, what about the heart? All of us know what happened in ticagrelol, but I will focus on the adenosine. Look on the adenosine, it will decrease the ischemic reperfusion injury and decrease the induced pharmacological preconditioning. Also, it will decrease the electrical condition and conducting. What about the RBCs and the platelets? The adenosine increase the platelet inhibition modulated inflammation, which is very important in acute coronary syndrome patient. And here is the onset and the offset and how potent is and how rapid it's working on ticagrelol. This is a randomized study, head-to-head between ticagrelol, clopidogrel, and placebo. And what we will see that the onset immediately after 13 minutes of giving ticagrelol, there is platelet inhibition almost more than clopidogrel by 41%. That's why ticagrelol is the first reversible binding oral B2Y12 receptor antagonist. Not only the first half minutes, but on the same time after 2 hours, in comparison with the clopidogrel, we will see that 88% it will decrease in the aggregation of the platelet. On the other hand, we have only 38% in the clopidogrel group. This shows how fast and how rapid and how potent we will inhibit the platelet aggregation in comparison between ticagrelol and clopidogrel. Also, here is the clinical pharmacology between the ticagrelol, clopidogrel, and prasugrel. All of you know who is the prodrug and who is the active. Also here, very important regarding clopidogrel, require metabolic activation. Clopidogrel delay onset of action, irreversible B2Y12 receptor binding, and we have consideration intra-individual variation. And in the other groups, prasugrel, it's require also metabolic activation, irreversible B2Y12 receptor binding, and increase the risk of major bleeding in comparison with clopidogrel. This is a little differences between the 3 arms, clopidogrel, prasugrel, and ticagrelol. Also, we have some limitation in using prasugrel in such TIA patients and low body weights and the risk of bleeding. This slide is very important, which show when to stop the antiplatelet in elective surgery. Patient will go to elective surgery, he's on antiplatelet. If you see here, prasugrel, you should stop it 7 days before the elective surgery, clopidogrel 5 days, and ticagrelol only 3 days you can stop it before the elective surgery. And here, this is very important slide, show escalation and de-escalation between the 3 groups of antiplatelet. Keep in your mind, in the acute setting, always almost loading. Very important. But in the chronic setting, there is some differences, especially when we do escalation and de-escalation between ticagrelol, clopidogrel, clopidogrel, ticagrelol, prasugrel, ticagrelol, or ticagrelol, prasugrel. This is very important, but just keep in your mind, in every acute setting, you must load. Okay? What about the guidelines? The guidelines also said you can use the antiplatelet, and here is very important. Prasugrel is recommended in B2Y receptors patient proceeding to PCI, loading and maintenance. Ticagrelol is recommended irrespective of the treatment strategy, invasive to conservative. This is in the guidelines, and also clopidogrel loading and maintenance, we can use it, and all of us know now what is the difference between the 3 groups. And this is very important to compare efficacy and safety between the oral B2Y12 inhibitors in acute coronary syndrome. Prasugrel and ticagrelol reduce the ischemic event and increase the bleeding in comparison with clopidogrel. But a significant mortality reduction was observed with ticagrelol only. There was no efficacy and safety difference between prasugrel and ticagrelol, and this is well known in the Plato study. Everyone here in this room known what is Plato. It's a trial of platelet inhibition and patient outcome. This is a trial انعملت head-to-head between clopidogrel and ticagrelol. It's a large randomized clinical trials supporting the use of the 12-month of dual antiplatelet with ticagrelol 90 in comparison with clopidogrel. What about the primary outcome? Before the primary outcome, we will see the characteristics between the 2 groups, the ticagrelol group and the clopidogrel group, whether the risk factors, hypertension, dyslipidemia, diabetes, myocardial infarction, or cabbage grafting, etc. And here also the characteristic of the group. You will see all of them, it's a high-risk group of acute coronary ST elevation, non-ST, unstable angina, and the age. What we result? We result that ticagrelor reduced the relative risk early over the 12 months in comparison with clopidogrel, with a relative risk reduction almost 16%. Also, what about the reduced mortality? Ticagrelor in comparison with the clopidogrel show a reduced benefit of the cardiovascular mortality, as I said, significantly within the 12 month, within risk relative, with 21 relative risk reduction. And this is also supported by the Plato. Also, ticagrelor reduced myocardial infarction event significantly with a relative risk reduction 16%. And in non-ST elevation also in the Plato show a consistent reduction in recurrent cardiovascular event in comparison with the clopidogrel with a relative risk reduction 17%. And here also regarding to recurrent cardiovascular event, we will see that ticagrelor demonstrates 16% relative risk reduction in MACE in a patient with ST elevation in compared with clopidogrel. And this is a very important slide, show that if the patient in acute coronary syndrome and have normal GFR, such as 90, 80, there is no difference between ticagrelor and clopidogrel. But once there is a severe renal impairment or moderate, below 30, you see the arm of ticagrelor is better than the arm of a clopidogrel in related to thrombotic cardiovascular event with this moderate to severe renal impairment patients. And this is very important. Also stent thrombosis. We said the inhibition of the platelet in the first half hour and then in the coming hours, it's potent inhibition more than 90% reduction in the platelet. That's why ticagrelor reduced the stent thrombosis over the 12 months compared with clopidogrel by 33%. Also, in overall bleeding, is there a difference between ticagrelor and clopidogrel? There is no differences between regarding to bleeding risk. And here also demonstrate no increase in overall major bleeding or fatal bleeding head-to-head between ticagrelor group and clopidogrel group. And here again, no increase in overall major bleeding or fatal bleeding between the both arms. What about the dyspnea? We know that the incidence of dyspnea in ticagrelor group is more, and we see before the previous slide the benefit of adenosine accumulation, but when to stop this medicine regarding to dyspnea. You should fulfill the diagnostic flow chart. First of all, patient with a new onset of dyspnea, the history and physical examination are important. زي ما تعلمنا كنا بسنة أولى وثانية وثالثة ورابعة وخامسة طب. History is very important. يعني once أنا مريض معطيله ticagrelor صار عنده dyspnea, think once, twice, and third, is it the dyspnea related to drug or to the MI event or to the heart failure event or to the COPD event? You should focus on the history, very important, before stopping the medicine. And you, all of us, know how potent is this drug. Also, the cause of dyspnea, as I said, may be difficult in acute coronary syndrome patient treated with ticagrelor. Dyspnea is a common in ticagrelor side effect more than 10%. Acute coronary syndrome patient reporting dyspnea have a high risk profile and should be managed with the most effective treatment strategy, as I said. The balancing is very important between the side effect and each single drug is needed. You must sit 1 to 2 minutes more with the patient, explain the benefit and the side effect, but only in the case of persistent and intolerance ticagrelor related dyspnea, here you should discontinue and de-escalation of the drug. And this is a chart. If you want interested in this busy child, you should fulfill any patient of dyspnea on ticagrelol, how to manage it. But again, history is very important. Here it's very important. Is it safe? Yes, safe in elderly patient, in diabetic patient, and CKD patient. And this slide is very important. Can be used in a broad spectrum. You see here the difference between ticagrelol, prasugrel, and the clopidogrel. The one in the green one is approved. The one in the red one is contraindication. If you see in the dark one, cabbage, non-invasive, in a prasugrel group are contraindication. State of TIA, of stroke also. Weight less than 60 milligram or age above 75, still there is a limitation of using prasugrel. And here is the role of ticagrelol in these patients. What about the de-escalation? If we are shifting from drug to drug, from potent to less potent, what will happen? De-escalation from ticagrelol to clopidogrel increase the platelet reactivity. Ticagrelol has superior platelet inhibition in comparison with the clopidogrel. Switching from ticagrelol to clopidogrel, it will increase the platelet reactivity and the incidence of thrombosis. Variable platelet reactivity with the clopidogrel may have an impact on the clinical outcome. To conclude, treatment with ticagrelol as compared with the clopidogrel in a patient with acute coronary syndrome significantly reduced the rate of death from vascular causes, myocardial infarction or stroke. Similar benefit was seen for the individual component of death from vascular causes and myocardial infarction. The benefit effect of ticagrelol were achieved without a significant increase in the rate or the major or a fatal bleeding. The benefit of ticagrelol over clopidogrel were seen in a patient who had an acute coronary syndrome with or without ST elevation. The benefit with ticagrelol were seen regardless of whether invasive or non-invasive, and the superiority of ticagrelol over clopidogrel regarding the primary endpoint, as well as the similarity in the rate of major bleeding, was consistent between the two subgroups. And thank you for listening.
Great presentation. So a couple of questions, if you don't mind. You know, the guidelines says that, per guidelines, 5 days for ticagrelol. But as you said, 3 days sometimes because the half-life and it's a reversible inhibitor. Do you care to comment on this?
Definitely in the practical, yes, the guidelines said 5 regarding to ticagrelol and clopidogrel, but
even ticagrelol.
Yes, 5 days. But in our practice, once you stop it 48 hours or 3 days, the risk of bleeding, it will not increase in our practical event.
Okay. And do you have any? Oh, Dr. Basil.
Dr. Ghassan.
No. Yes, you have Dr. Hassan question. Go ahead.
احكي قيس.
لا انت اسال.
طيب يعطيك العافيه. يعطيك العافيه محمد. طيب احنا عارفين انه التيكاجريلول is more potent and at the same time it's more bleeding. يعني we see the bleedings more مع التيكاجريلول than الكلوبيدوجريل. I think we have not to يعني مش لازم نعطي يعني overall all the patient the same. We have to categorize the patient. And I think this is one of the problems in the emergency room. They will start loading before calling the consultant. And this is, I think, one of the problems we have here also in Jordan. After they assessing the patient and seeing he is high risk, not high risk of bleeding, high risk of thrombosis, not high risk of thrombosis, young, he has some history. At that time, you can decide which is the best for him to use as an antiplatelet therapy at the beginning. I think this approach is more better than we are using. Yes, this one is better than that one. I think every patient has his own way on best.
Agree, Dr. Hassan. But regarding the potency, we know that prasugrel anticoagulant are potent. Clopidogrel are non-responsive, and the risk of stent thrombosis are more than the arm of the clopidogrel than the arm of the ticagrelor and prasugrel. Prasugrel, who were the only one who have the bleeding risk more. And regarding the arm ticagrelol and the clopidogrel, regarding the major bleeding, والfatal bleeding, guys, the same. But the risk of bleeding in prasugrel are more. This is one point. The other point, there is some limitation in using prasugrel in some patient, age, low body weight, previous TIAs. We can't use prasugrel.
Renal impairment. I will continue using of PCSK of glycoprotein to 2B3 inhibitors, using of anticoagulation after the myocardial infarction. If there is a large of a thrombus, you want to continue the anticoagulation for 3 days at least. So these all are giving us a limitation of the ticagrelor in general.
And also you see the slide regarding the platelet aggregation inhibition, head-to-head comparison, ticagrelol versus clopidogrel in the first 30 minutes, and then how many platelet aggregation inhibition in the arm of ticagrelol. In the first 30 minutes, we have almost 40%, in the spite of that clopidogrel 8%. And after that, we have 90% reduction in the platelet aggregation in the arm of ticagrelol group than almost 40% in the clopidogrel group. This shows how يعني بدناش نقول والله more potency. لا, there is other factors.
If I might say, I think the point, Dr. Ghassan, is well taken. I agree with you on two major points that you made. Number one, upstream loading of P2Y12 should stop being a habit. In non-ST-ACS, it's not indicated. Even in STEMI, it's 2B. So upload before going to the cath lab, unless you expect your patient is going to be there for too long, beyond 24, 48 hours, then maybe there's some room for uploading. Otherwise, if you're taking him within 24 hours, do not upload with P2Y12. Now, for the choice of P2Y12, I agree, you have different tools, and you should pick according to your patient.
Definitely.
As far as the bleeding, if you want to put it in a kind of gestalt way, prasugrel probably is the highest rate of bleeding, followed by ticagrelor, then followed by clopidogrel.
Totally agree.
The reason in a few discrepancies is how these trials were designed.
Yes.
I'm gonna give kudos to actually the Plato trial designers. They really designed it in a way to avoid showing bleeding problems with ticagrelor. First, that's why the guidelines are 5, despite the fact that it actually gets out of 3. They opted not to compare themselves with clopidogrel as a superior one. They said, let's just go head to head, 5 to 5. So that's why guidelines go by the trial, although technically and theoretically, you should be out of your system in 3 days. The second thing is how they defined bleeding. When they defined bleeding in Plato, they went for major bleeding non-cabbage.
Yes.
They didn't go for the minor ones, although technically in real-world data, there is a slight increase in GI bleeding in comparison to clopidogrel. Okay. Now, prasugrel, yes, it has more, but
definitely.
But if you think of ISAR React 5, it shows it's head-to-head with ticagrelor. But again, how did they define the bleeding? So overall, if you want to take different meta-analysis, all of these trials together, overall, prasugrel slightly higher, followed by ticagrelor, then clopidogrel.
Reset that in a fatal and major bleeding.
Bleeding, yes.
Okay, there is one point. Do we need really as much as that potency to decrease platelet inhibition and to make more? Do we need it? Actually, stent thrombosis not anymore seeing as much as far as the old days, because nowadays we have a new technology in the cath lab, we have better stenting, we have better...
Dr. Ghassan, if we said per se, not on the technical issue in the cath, and regarding the platelet, this is regarding in acute coronary syndrome, MI.
Good question. Yes. I think the reason we are seeing less stent thrombosis is actually using the newer P2Y12. Of course, our techniques and equipment is better. Of course, our stents are better. They're thinner struts. They have a better type of elution and different types of polymers, which make them less likely to clot. But I think the biggest difference is us using the newer P2Y12s. with less resistance than the one with clopidogrel. Okay, I think we should risk stratify. We have different tools. We should pick and choose according to our patient. If we feel our patient is a very high risk patient, he has a lot of potential, side effects like shortness of breath, COPD, asthma, and
Go to prasugrel.
he's not a high bleeding risk, prasugrel is the way to go. If you feel your patient is the usual run-of-the-mill STEMI or
Severe renal impairment.
I probably would go with ticagrelor. If I feel my patient is a very high bleeding risk, and and I don't want to use one of those, or he has a lot of dyspnea, and he's not a candidate for prasugrel, and then clopidogrel. Or if I want to do medical management, I know ticagrelor can be used for medical management in contrast to prasugrel, because Plato did include those patients. But CURE trial is much stronger trial to show you that clopidogrel works for medical therapy much more than a small subsegment of patients in Plato. See, so
Okay.
if I'm going to pick a medication, if I'm going to pick a medicine for medical therapy, I'm not going to pick ticagrelor. With all due respect, I'm going to go for clopidogrel.
Especially in severe renal impairment patient.
Why? CURE trial. So again, we have different medications, different tools for different patients.
And choose the best antiplatelet for the best patients.
Yes. All
This is
right,
the key.
so we come to the conclusion. Thank you so much,
Thank you,
Dr.
thank you.
Mohammad.
Thank
Really
you, Hassan.
appreciate
Thank
it. I think we have a break.